Perfect.
So I want to welcome everyone to today's session. We have Dr. Ziad Soul from London, Ontario, in Canada, here with us today. He'll be talking on disease-modifying therapies in sickle cell disease. Dr. Ziad is one of our most respected hematologists in Canada, and he works both out of the Victoria Hospital and St. Joseph's Health Center. And we are very honored that he has given his time to help us this morning to really, identify and to educate us on modifying therapies for sickle cell disease. So without taking much more of your time, I'll pass it to Dr. Saul. But before I do that, a few housekeeping. So Dr. Saul will present for about 1 hour, and then we will have about 30 minutes for questions and answers. So we have the Q&A box right there at the bottom of your screen. If you can type in your questions, as Dr. Saul is presenting, you can type in your questions. If you want to chat, you have a comment, you can also use the chat box. So when he finishes the presentation, then we will go over the questions. Thank you very much. Dr. Saul.
Thank you so much, Leonard, for that very generous introduction. Leonard, do you think we have all the participants logged in, or are we still waiting for some?
We're still waiting for some, but it's about 11:02. Maybe you want to wait maybe about 3 minutes?
I don't mind. Yeah, I don't mind.
Okay, so I also have Sanjeev on the there, right there. Sanjeev, hello. Can you unmute yourself and say hi to everybody? Sanjeev and I work together at the Global, and is also volunteering with us today on this webinar. So I want to give a warm welcome to Sanjeev Wadwani, all the way from Australia, Switzerland, right?
In Switzerland, yes. Thank you, Lanre, and hello and welcome, Dr. Soul. Looking forward to your presentation.
Thank you so much. We'll wait a few minutes because the first couple of slides were just setting the stage for the objective. So I want people to hopefully catch this part.
No worries. Thank you.
It's a bit of a sunshiny, cloudy, half rainy day here today in Canada.
I know, I know. I am in Barrie, and it's very cloudy here in Barrie.
Yeah, it's a turn of the seasons.
I know. I tell you. So it's we wait 1 more minute to 11:05, and then we'll start. We have more participants joining now.
Yes. What time is it in Switzerland now, Sanjeev?
In Switzerland, it is just past, good question. I've been in meetings all day. Just past 5 p.m. in the evening.
Wow.
I'm going to put some comments on the chat box for everyone.
I'll open my chat box as well so that I can see it at the same time.
Yes. Well, I can definitely tell you that with Zoom, we get global quickly because we have people from India also on this webinar. That's very nice. And I know we have people from different parts of Africa also registered for this session. So, you know, this is knowledge and education without bother. So that is very good. So
that's excellent.
yes.
I'll let you tell me, Landra, when we're ready to go.
Okay, no worries. So I think we can actually start. It's about 8 minutes past 11, just to be mindful of those who called in on time. Thank you, Dr. Sol.
Absolutely. So thanks for having me. Again, it's an honor to be here. I mean, I'm in the comfort of my own home, but it's an honor to be connected with you guys through this venue. So SCAGO has done a lot of excellent endeavors in the past to spread knowledge and education, and I'm very happy to be part of it. So I was asked by Lonray to address some of the new treatments that are out there for sickle cell disease, some cures that are available. So as Lonry mentioned, I'm a hematologist at London Health Sciences Centre here in London, Canada. And we have a sickle cell disease program we started about 3 years ago. And we we've been able to offer treatments for a variety of different types of sickle cell disease. And these are some of the ones that we've discussed with our patients. I also work in the transfusion medicine lab, and as you know, transfusion is a big part of therapy for sickle cell disease. We won't really touch on that too much today, but here we are. So why do we even need to talk about disease-modifying therapy? Why not just go on with symptom management, pain management, chest syndrome management? Well, we know that in sickle cell disease, unfortunately, reality is that without disease-modifying therapy, adults with sickle cell disease do die prematurely. The median age of death in an adult who may not be receiving the treatments that they need optimally was 39 in 2006, and we've been able to improve that with treatments over time in 2015 to the age of 46. So that's still not ideal. It's a median age. It's not the maximum by any means, but it's not satisfactory at this point. So more and more is being done to offer curative therapies and definitive therapies for sickle cell disease. One of the main therapies is going to be stem cell transplantation. That's kind of pretty novel. Not everywhere is offering it, and I'll discuss that a little bit here today. But you can see from this graph, the y-axis shows the percentage of death, and the x-axis looks at
I'm very sorry, Dr. Sihad. I'm very sorry. The participants are saying that your volume is low. Can you increase your audio volume a little bit? Thank you. Thank you.
I tested my volume and it was good. Let me see. Is this better by any means?
Yeah, it's a little bit, it's a bit better. Thank you.
Okay, good. So I just have to remove all these pop-ups from my screen. Okay. So, we can see that over time, if you, for example, just take the 20 to 24 years of age, and you can see that over the years from 1979, 1989, 1999, and 2006, there has been improvement in death. but we haven't seen the same improvement in the adult age group. So we've done really well with preventing problems in children by adding vaccinations and starting hydroxyurea early in life, etc. But in the adult age group, it seems that we're having much less success with giving definitive therapies that will prolong quality and quantity of life. So this is where these new disease-modifying therapies should hopefully help. The line I've put in the middle with the blue line I've put is really just showing how with age, there tends to be a higher percentage of death, which is much faster than the general population. So we need to do something to offer more. And to modify sickle cell disease, we're not only looking at the sickling of the red blood cell, which I'm going to explain a little bit about how the red blood cell in sickle cell disease will change shape when there's stress, like cold weather exposure or infection or dehydration. That's just one part of sickle cell disease. The other parts that are less well discussed are really that your white blood cells that are supposed to fight infection, they're constantly activated and agitated and very sticky and adhesive. And that causes the blood flow to be also slower, leading to bone pain and other problems like stroke. And the third part of the sickle cell disease physiology, or the way it works in the body, is that the platelets, these are kind of brownish little tiny cells in our blood that are supposed to stop bleeding from happening. They become very activated and angry because of the constant sickling and damage to the blood vessels, and they end up making blood flow also slower in certain parts of the body, leading to organ damage. So when we think about disease-modifying therapies, we're not only focusing on the red blood cell, but we're also thinking about all these other aspects of our blood that are causing problems. So the disease-modifying therapies I want to address today are hydroxyurea. That's really the mainstay in most of the world. So it really behooves us to really understand it and know the benefits and know why we focus on it so much in clinic. Then there's stem cell transplantation, which is really rising as the definitive treatment for sickle cell disease. Gene therapy is experimental, but it's also an option. In the United States, they've succeeded in getting FDA approval or Food and Drug Administration approval for drugs like voxelotor. They also are going to be having medications like crizanlizumab. L-Glutamine is another option that's been studied. And phlebotomy, which is bloodletting, removing blood. You may not know a lot about this, but for patients with SC type of sickle cell disease who have really high hemoglobin, phlebotomy has been shown in some cases to be helpful. And I didn't mention in this list blood transfusion, right? So regular blood transfusion or exchange blood transfusions are definitely disease modifying because we're removing sickling red cells and transfusing healthier red cells. And I didn't include it in this list because it's a well-known area that's offered as first-line therapy. So how does hydroxyurea work? We know that we just talked about red cell sickling and platelet activation and white cell adhesion. It actually works on all of these parts. It increases the amount of good hemoglobin. It's called hemoglobin F, or fetal hemoglobin. And by increasing that, it proportionally decreases the sickling hemoglobin. So we see quite a bit of improvement in patients who are taking it regularly. Not as much improvement in patients who maybe don't tolerate it and don't take it, or they forget to take it. It also suppresses the white blood cell count, which is a good thing because those white cells are very sticky. And it makes red cells bigger and less dehydrated, so less prone to sickling, and it removes some of the toxins that red blood cells produce. So I know it's a complicated figure, but just to show you that the molecule works in different ways, that's why we love it so much. And we even tolerate the side effects, which are considered to the overall health of the patient. The side effects of hydroxyurea are smaller than the huge benefits we're going to get out of taking it. and I'll show you the benefits. So how we prescribe it is, at least in Canada, we have 500 milligram tablets. In other countries, they have different sizes of tablets. It comes in liquid form for children as well. And we usually give it, we request that the patient take it daily for a week, and then increase the dose gradually over time. So double the dose after about a week if they're tolerating it. And we keep increasing until, really until the patient says, I can't tolerate the side effects anymore, because there's no ceiling effect, meaning there's no downside to increasing the hemoglobin F so much that your sickling hemoglobin drops. Really, that's kind of a good way to counteract the side effect, the effects of sickle cell disease. Of course, with hydroxyurea, like any medication, we want to look at the blood work. So patients will be asked to come to our clinic every 2 weeks initially, and then we stretch it out to every 1 to 3 months, depending on how the patient is tolerating everything. So it is a commitment. When you take hydroxyurea, you have to commit to the blood work and the follow-up. It's not to take a prescription home and never show up to clinic again. That makes us very nervous. And hydroxyurea is available in North America and a lot of parts of the world, but we acknowledge that it may not be available in parts of the world where sickle cell disease is very common and prevalent, which is unfortunate. Sorry, my computer is reminding me to update. I said we'll do it tomorrow. So when your doctor is doing hydroxyurea blood work, monitoring blood work, really what they're looking at over time is that your hemoglobin F fraction, or the hemoglobin F target, is going to rise from what it's supposed to be naturally under 5% to about 30%. So anything between 20 and 30% of this good hemoglobin F tells us that the hydroxyurea is working. So it's not enough to take a pill and never follow up your blood work, because you don't know if that dose is going to be enough for you. Every person has a different dose that works for them. And it really depends on a variety of things like, your kidney function, your liver function, and a few other things. Only when the hemoglobin F concentration is about 30% is it possible for the number of protected cells in your blood to be approximately 70%, because each cell has a different amount of the hemoglobin F. Hydroxyurea has been studied extensively, especially in sickle cell disease. It actually was introduced many years ago to treat other diseases, but it was found that sickle cell disease patients will really benefit from it. So the baby hug study was one of the main studies, and it looked at 193 infants, believe it or not, 9 months of age to 18 months of age, very young, and half got hydroxyurea and half got placebo. And they were followed for 2 years. And you can see in the graphs, the red bar is the placebo and the gray bar is the hydroxyurea. And what we're tracking is the number of events of pain, chest syndrome, which is the difficulty breathing presentation in sickle cell disease, hospitalization, meaning being admitted to the hospital, and dactylitis, which is swelling of the fingers in babies, which indicates sickling in the fingers. So they track them, and there's a huge response to hydroxyurea. And this is a randomized controlled trial, meaning they collect enough patients to really make sure that anything that's affecting response is kind of evened out across all the patients. So the hydroxyurea drops the amount of pain by half, almost removes all the dactylitis symptoms, the finger swelling symptoms. Chest syndrome, which can kill, was reduced by by 2/3, and hospitalization was dropped as well. So, it's hard to not suggest hydroxyurea to patients when they're suffering from all these symptoms. It's really a very helpful medication, especially in a world where we don't have tons of other options. So those that got hydroxyurea did better with no differences in infection, organ toxicity, and growth. There was also a different study published in 2019. and they looked at hydroxyurea for children in sub-Saharan Africa, 635 children. You can see it's much easier to get bigger numbers of patients when you study in sub-Saharan Africa. And it was found that 50% less pain crises resulted from hydroxyurea, less infections, 50% less infections, 67% less blood transfusion need, and 70% fewer deaths. So it's really it's really beneficial in many age groups and many parts of the world. Vaso-occlusive episodes, we're going to call them VOE, which is really when the blood stops flowing because of the sickling. So they studied it in adults as well with SS disease. You might know that your sickle cell disease is, can be classified as SS, S beta, SC, SD, SE. There are many types of sickle cell disease. The most common and the most severe of which is SS. So they studied about 300 adults who have been suffering with 3 vaso-occlusive episodes per year, at least. And they gave them hydroxyurea and they reached the maximum tolerated dose. That's what the MTD. About a third of them were able to reach the maximum tolerated dose. And they were able to drop the number of crises per year from 4.5 to 2.5 on average. That's pretty significant when you think about having to go to the hospital 5 times a year versus having to go to the hospital 2 times a year. So that's a good response. We weren't able to stop all problems, but it decreased it quite a bit. Chest syndrome dropped from 51 times to 25 times, and blood transfusions were reduced. And we know that blood transfusions are not without risk, so it's good to avoid blood transfusion. And this is a fancy graph showing how hydroxyurea versus placebo, hydroxyurea had less events or less problems. So, no wonder I'm spending a lot of my time on hydroxyurea. The bulk of the slides will be on it. I know it's a review of the last talk we did on the WhatsApp chat group. If you attended, we did a WhatsApp chat session on with SCAGO. But I do want to review these slides because they serve as a good reminder. So we talk a lot about SS, and we don't want patients to feel left out if they don't have SS, because S beta thalassemia is very severe. Hemoglobin SC can be very severe as well. So what's been done to study these patients that are not SS? And what we do is we take a finding from SS and we say, well, it must apply to everybody else. It's not 100% true, but that's the information we have, and we try to work with it. But what has been studied with S beta thalassemia is they took patients and gave them hydroxyurea, and they found that on the table, if you look at the table, non-hydroxyurea patients had many more problems, more strokes, more pulmonary hypertension, more sudden death, more acute chest syndrome, etc. So 24.6% had those problems versus 9.9% with hydroxyurea. So a big change. And then the graph tells you survival probability. So taking hydroxyurea gives you higher survival, the higher curve there. And without hydroxyurea, it's a lower survival. So, we keep finding the same thing in all types of sickle cell disease. So really, it's something we always talk about in clinic. SC, similar findings. They had, this is a review of different studies published by Steinberg, Iyer, Zimmerman, Wang, and the study that, the Viscaridu study from 2010. And, all of them found that the hemoglobin is, although the hemoglobin may not be super different, the amount of hemoglobin F can be different, and the patients just do better overall. So we do offer it for SC. So that's all well and good. We talk about pain, but what about the other things we discuss in clinic with patients, like vision problems that can happen in sickle cell disease, kidney problems, bone problems. So I'll discuss quickly here. Retrospective review And, you know, no pun intended in what else can we see with hydroxyurea. But retrospective review of over 100 children with sickle cell anemia, about 10% of them had retinal disease. So that's where the retina behind, in the back of the eye is diseased with sickle cell disease and starts detaching, and people can become blind. And I have at least 2 patients in my clinic that are unfortunately blind in their like early 40s. So what could we have done for them? Giving hydroxyurea will lower the, giving hydroxyurea for patients with a low hemoglobin F can raise their hemoglobin F values, and those that have higher hemoglobin F values were found to have less retinal disease or retinopathy. And then 8% get retinopathy with hydroxyurea, but 14% get it without hydroxyurea. So it's not 100% effect. It can't protect the eyes 100%, but it seems overall the odds are it'll help. It'll help drop the risk by half. What about the kidneys? We know that the kidneys, if they don't get oxygen because of sickling, they start behaving badly, meaning they start leaking protein. And I also have a patient on a kidney transplant list, like they're waiting for a new kidney. So, you know, we want to do everything possible to stop the kidneys from not working early in life. So hydroxyurea also improves kidney function over time. 26 adults, it's a small study, but 26 adults in Brazil with sickle cell disease, they found that there was less urine protein in them when they take hydroxyurea. And 149 adults in a different study also were found to have less leakage of albumin and protein into their urine. So it may provide added benefit when kidney medications are started. So sometimes we use hydroxyurea along with what we call ACE inhibitors or certain kidney protecting medications that the kidney doctors start. So we start them together to help the kidney. And the kidneys are very important because if the kidneys stop working, then all your medications that you're taking will rise to toxic levels in your blood. So the kidneys need to work to flush out everything. Men with sickle cell disease will know that they have a high risk of priapism. Priapism is a very painful erections lasting hours and hours. These are not pleasant erections. These are painful, can lead to damage of the penile tissue and even erectile dysfunction. Patients that have priapism for over 3 or 4 hours need to come to the hospital to have a needle put in the vein and in the penis to remove the blood by a urologist. So this is something that can really, people don't like talking about it because it's private, but we make people talk about it because it's part of your health. So hydroxyurea actually does improve priapism as well. In a Brazilian study this is a tiny study, just 5 patients, young patients under 35 years. They gave them hydroxyurea and there was a response within 2 months. And what they've published is that one person became asymptomatic for 3 whole years with normal sexual activity. Another person was asymptomatic, meaning no priapism, for 6 years, and so on. So people did have symptom relief for many years if they take hydroxyurea. Obviously not something we study in women because it's not relevant, but at least for the men, it's something we need to discuss. Even the children. So children get natural erections, and those can be very painful and can cause damage over time. So you might have heard of the term osteonecrosis or avascular necrosis. That's where the hip joint or the shoulder joint or the knee joint or any joint really, it's supposed to be very nicely lubricated so that you can run and move around and lift and do all sorts of things. With sickle cell disease, the edges of the joint don't receive oxygen because of the sickling. So they die off and they become very jagged and rough. And then people have shoulder pain, they're unable to lift things at work. they can't walk. Some people become wheelchair ridden. Some people have multiple surgeries, very young, in their 30s and 40s. So we don't want this to happen. It's actually very common in SC type of sickle cell disease. So if you're told by your doctor that you have SC type and it's mild, don't worry about it. That's not true. SC can give you this avascular necrosis joint problem, and it can give you higher rates of the retinal disease, the vision problems. So SC patients are screened specifically for those things. So this study, and SS and S beta thal can also get it. So them being more common, they were studied, and it was found that hydroxyurea improves pain, improves problems with avascular necrosis, etc. So we're not really finding anything bad about hydroxyurea. All the findings in sickle cell disease are good, knowing that there are side effects. But it really is a disease-modifying therapy that should be taken very seriously. Are we using it? They did a study in the United States looking at, just randomly looking at everybody with sickle cell disease that's coming to the emergency department. And they just asked them, are you already on hydroxyurea? 3/4 or 3/4 of patients were not prescribed it. So they were either not seeing a doctor, or their doctors were not offering it to them. Sadly, a lot of my patients, they're followed for years and years by their family physicians. And really, family physicians, they're excellent at many things, but you need a hematologist. You don't need generalists that may not know the treatments available and the follow-up required. So there's no reason why 75% of patients that are coming to the US emergency rooms are not on some sort of disease-modifying therapy. So this is really not acceptable. And really what we find is that some patients may not self-advocate very aggressively. Like, you really need to speak up when you have sickle cell disease, because you can't see the disease. You need to do blood tests. You need to do x-rays to see the avascular necrosis. You need to do MRIs to find the stroke. Sickle cell disease is not very obvious. So don't leave it to general practitioners. You need to go to a specialist so they can give you the disease-modifying therapy that you deserve. Some reports out there, the company that makes hydroxyurea is obligated to say, to list all of the side effects. In some animal studies of hydroxyurea, there were some birth defects. Human studies of hydroxyurea have shown no birth defects. So although the label on the drug says don't take if you're pregnant, I have had a few patients take it during pregnancy because it was their best option, and they've had perfectly healthy babies. And that's just my experience. But when you look at the literature, there have been at least 20 case reports of people having perfectly healthy babies on hydroxyurea. So, we do counsel that there's this theoretical risk that there will be anomalies in the babies, and, we'll check on ultrasound to make sure baby's healthy and let you know. But really what's happening is people are taking this medicine and they're doing great. And they're having safe pregnancies, better pregnancies, and healthy babies. So in this is a study, one of the bigger studies that was done. They just happened to find that some patients on the studies became pregnant. And so they decided not to stop the pregnancies, and there were live births, and the rates of miscarriages were not different from the general population. So it's not thought that hydroxyurea causes any problems. So before 1998, 15 pregnant women used hydroxyurea. 9 in the first trimester had no birth defects, and people that are taking it in the second and third trimester also had healthy babies. In 2010, 2 more women were reported with sickle cell disease and hydroxyurea and had healthy babies. I myself reported, we just published a report of someone who had very terrible sickle cell disease and couldn't even tolerate blood transfusions. We gave her hydroxyurea throughout her pregnancy. Now she has a beautiful baby. Very difficult pregnancy, but she has a healthy baby. So the hydroxyurea is, we're not seeing that it's causing problems in any pregnancies. Breastfeeding, we do, however, recommend that, if you're breastfeeding the baby, wait until it's out of your system and then maybe take out the breast milk to feed the baby. But while you're taking the hydroxyurea, you would have to discard that breast milk. And some women actually decide not to take hydroxyurea while they're breastfeeding, or vice versa, not to breastfeed at all, depending on their disease. Okay, so that was hydroxyurea. I'm just gonna push ahead considering the time. Stem cell transplant has been discussed quite a bit. I'm not a stem cell transplant doctor, but I certainly screen my patients that are, especially the young patients that can benefit from stem cell transplant. I screen them and discuss it with them and counsel them, and then refer them to centers in Canada that will transplant sickle cell disease, because most centers in Canada have no experience with transplanting sickle cell disease. They have experience transplanting leukemia and all sorts of different blood disorders, but sickle cell disease is a newcomer in this area, and it's really been studied in research trials. And for us to make it standard of care, there's really only 2 or 3 centers in Canada that will do it. There's Toronto and Calgary, and I believe in Montreal as well. But you can't find access to transplant too easily, and I'll tell you why. So in Canada, our first reported cure of sickle cell disease happened in Alberta, the province of Alberta, in the city of Calgary. And this young woman was the first patient cured of sickle cell disease by transplant. And she goes and does a lot of nice talks telling her experience to everyone. And it's a really positive experience for her that she's promoting, and that's excellent. We know that not everyone's as fortunate to have the blood donor that can, or a transplant donor that can be compatible with them. But let's just talk about what we know. In 2017, there was a very important publication of 1,000 patients with sickle cell disease who underwent something called matched sibling stem cell transplant. So for stem cell transplants to be successful in sickle cell disease, we found over time that you have to have a sibling, probably with sickle cell trait, that is matched to you in certain things that define your blood. We call those things human leukocyte antigens, or HLA. If you're not matched for HLA, then you would reject those stem cells. And there's also a risk of death if you attempt an HLA unmatched sibling transplant. But in this case, they took 1,000 patients with sickle cell disease who had HLA matched sibling stem cell transplant. They looked at their experience from 1986 to 2013. And in transplant, they do this thing called 5-year survival. They look at everyone 5 years later and they check if they survived. And it's about 93% survival and about 91% event-free survival. Event-free meaning they didn't have relapse of their sickle cell disease or problems that are related to sickle cell disease. So really what stem cell transplant is you're taking, look at the left, the woman on the left, you take stem cells from the blood, connect her to a machine, and it collects the stem cells. And then they're processed. The recipient, or the person who has sickle cell disease who's going to receive them, actually has to get very strong chemotherapy to suppress their bone marrow from making any more sickle cells. And then at an exact time, they have to get those stem cells from the donor. And it's a very orchestrated procedure. It has to be done by very specialized centers. Not everyone can do this. This is one example where they collect the stem cells through an IV, but there are examples where the stem cells have to be collected with a bone marrow biopsy and aspirate. So they have to put a needle through the hip bone and collect the bone marrow. That's another way of doing it. But it's a very long procedure, very risky procedure, but it seems to have succeeded in these 1,000 patients over, a 30-year period. So very promising, and now it's offered as standard of care in North America for sickle cell disease, if and only if you have a sibling match. So why aren't more patients getting stem cell transplant? It seems like, this is the cure. So why aren't we offering it to everybody? Well, it turns out only 15% of patients will have an HLA-matched sibling donor. So that's kind of the bad news here. If you go back up, we have 1,000 patients. All of them happen to be that 15%. There's 85%, like probably 10,000 patients who just didn't have a sibling match and they couldn't even be eligible for the study. So that's the trouble here, and this is why now they're getting into, if only 15% have a sibling donor, why not look at other ways, other sources of stem cell transplant blood product? Because there are many stem cell donors in the world. Who's to say that one of them isn't HLA matched to you as a patient? Why does it have to be a sibling? So they're looking at that, and it's really under investigation. It's not really standard of care yet. But I really hope that in the next 30 years or so, some of these options will be available to all sickle cell disease patients. So these are the 4 different types of stem cells we can potentially look at. There's matched sibling donor, which I just talked about, and they're excellent. They have the best outcomes. However, only 15% of patients, or this slide says under 25% of patients, will be lucky enough to have a sibling match. Then there's unrelated adult donors. So these are donors around the world. You don't know them. They're not related to you. They're not your sibling. They're not your mother. They're not your cousin. They're just an unrelated donor who happens to have your same HLA type. The HLA types are very difficult to find, so we have to do international searches for these blood donors. And if you have one like that, who's to say you won't have a great outcome? I'll tell you, we have a patient in London who has a full match of an unrelated donor, and we got very excited. But due to the lack of experience in Canada with this kind of really experimental therapy, we just couldn't, the stem cell center couldn't ethically offer it to them and be confident that it's going to work. But they're still young, and maybe over the years the science will improve. The other option is something called haploidentical related donor. Haploidentical means half of your genes. So that usually means your mother or your father, which is great because most of us are still in touch with our mothers and our fathers, and they could be a potential donor. And we know that from other studies in stem cell transplant, like cancer transplants, that haploidentical really works. And there are some bad side effects, but they can work a lot of the times. Again, this is just experimental. That same patient I told you about also obviously, has this as an option to them, but same reason, we just don't have enough experience to just pull the trigger and do a stem cell transplant that's haploidentical. So all these things have a lot of risk. We really want to wait for a lot of excellent data, and usually from the United States or someplace with a lot more sickle cell disease. Canada has about 10% of the population of the US. So until we have more data, it's tough. I think there's in Atlanta, they offer haploidentical transplant to sickle cell disease patients. And the last option, which I would say is probably very difficult, is umbilical cord transplant. Umbilical cord stem cells, if you've preserved the umbilical cord of your kids, one of them may be a match, but it's such a tiny dose of stem cells that it doesn't always work. So anyways, just to give you an idea that there's a lot happening, the science is progressing, and I'm really hopeful something definitive will come up. But right now, what's accepted is matched sibling donor HLA identical sibling transplants, and that's going to be about 15% of patients. You might have heard of gene therapy. The gene therapy that's offered in experiments now for sickle cell disease is called CRISPR. There are other types, but I chose CRISPR because it's the more common one. And what CRISPR is, we take the patient's, the sickle cell disease patient's blood, we modify it, we fix that sickle gene on it's called the beta globin gene. We fix it, we make it normal, and then we inject it back into the patient, and we hope it works. Decent success rate. A small number of patients will relapse back to sickle cell disease. I think about a third. So it's not 100%, but they can get relief for like a year or two. Unfortunately, it's also chemotherapy. We have to suppress the immune system so you don't reject it, etc. But that's another very novel way of doing really disease modification, right? You're removing the disease altogether genetically. So that's one option. Again, they're offering it in Toronto, but for very specific age groups and very specific types of sickle cell disease. So I know not SC, I think it's only SS and S beta, and it has to be very young patients whose bodies are relatively healthy. But who knows, maybe in the future we'll offer it to adults. So kind of like transplant, but instead of finding a donor who is out there in the world and you may not find them, you just take your own blood and you fix the gene, and it's very expensive. I mean, luckily here we have a lot of studies that will cover trials. I mean, that will cover the cost of these experimental things. But one day, if it's standard of care, we hope that our governments will support through our healthcare plans. Okay, so I've talked about hydroxyurea, which is the mainstay of treatment that really everybody should be offered. And then stem cell transplant and gene therapy, we touched on them briefly. There are lots of cool new drugs that are coming out and that are receiving approvals, and they're specifically made for sickle cell disease. And this is excellent because, for the longest time, people just didn't talk about sickle cell disease. Scientists did not investigate sickle cell disease therapies. We investigated the disease and trying to understand it and look under microscopes to figure out what's happening. But people didn't seem to be doing a lot of studies on fixing it and treating it and improving it. They've done it for a lot of other diseases. Why not sickle cell disease? Partly because it's a smaller number of patients. But even though it's a smaller number of patients, it's a lifelong disease that's really difficult to treat. Really resource intensive, lots of hospital utilization. So if we're talking to governments and administrators, you need to show them that, this disease is resource intensive. So let's find a drug that will fix it and improve, the well-being of society as a whole. So these disease modifying drugs, I'm gonna list them. And some of them have had excellent randomized controlled trials that have shown benefit. One of the main ones that's received a lot of hype in the United States is voxelotor. They chose a very difficult name for it, but that's okay. So voxelotor is, when in 2019, basically, they looked at 274 patients in the HOPE trial, and they randomized them, meaning they gave some of them voxelotor, they gave some of them placebo. In this study, actually, they gave high dose voxelotor, medium dose voxelotor, and placebo to try to figure out which dose is best. And they found that the primary outcome, the main outcome, which was hemoglobin response, increased by about 1 gram per deciliter. In Canada, in metric, we say 10 grams per liter. So that's an increase in the hemoglobin from 7 to 8 or 70 to 80. That's pretty significant. That can help with the symptoms quite a bit. It can improve sickling. The response rate was 51% compared to just 6.5% in placebo. So it was really a good response. And so it got FDA approval. So looking at the study more closely, it was a phase 3 study published in the New England Journal of Medicine, one of the best journals in the world. So that's good because, sickle cell disease is getting a lot of high profile attention now. And most of the patients stayed on hydroxyurea. By the way, voxelotor is an oral medication, which is great. It significantly increased hemoglobin, reduced red cell breakdown, or what we call hemolysis, which is what makes patients jaundiced when the red cell breaks down. So it reduced that. And really what they found in the study is, this may be a disease-modifying drug. The way it works, by the way, is it stops the hemoglobin S from combining together and making like a line, a polymer. It stops that from happening because that's what twists the cell into a sickle shape. So voxelotor, being a hemoglobin S polymerization inhibitor, means it is a disease-modifying drug. Not tons of data yet on really like how the symptoms improve in patients, but because it's such a new drug and sickle cell disease is rising in prevalence in the US, the FDA approved it to be used. But keep in mind, people stayed on hydroxyurea because there's probably added benefit to both. Both medications work differently. So why not use both? This other medication, it's an IV medication, mind you. It's called crizanlizumab. They always choose really difficult names for these drugs. But crizanlizumab, it's an antibody. That's why the name of the drug ends in AB. It's an antibody to what's called P-selectin. P-selectin is this protein that, remember I talked to you in one of the first slides about how white blood cells become very adhesive and sticky, and platelets become very sticky and activated. Well, P-selectin is one of those sticky proteins. So this is an antibody that stops the sticking of these blood cells. So they took 198 patients, and it took 60 hospitals to find 198 patients that are eligible for this study. And they randomized crizanlizumab versus placebo. So similar story to hydroxyurea, the number of pain crises per year went from 3 to 1.6, so 2.98 versus 1.63, which means a drop to about half, right? In pain crises, which is excellent. Again, it doesn't stop all symptoms, but it really improves them. The time to the first crisis, the time from getting crizanlizumab to the first crisis, was prolonged to 4 months with crizanlizumab, versus on placebo, it happened about a month later. Time to the second crisis was 10 months with crizanlizumab versus just 5 months with placebo. To the second crisis, that is. Rate of uncomplicated crises. Uncomplicated means you didn't need to be, admitted to the intensive care unit for it. You didn't really need a lot of help with the pain crisis. It was just, maybe you used your home remedies for it. So rate of uncomplicated crises was 1 versus 2.9 or almost 3. So that's over half the amount was dropped. So again, another ray of hope. But it is IV. I think it's for 14 days, so 14 times over a period of 52 weeks. So 14 infusions over a 1-year period. So perhaps not the easiest thing to take, but for the benefit, it might be worth it for some people. Some people may want that type of benefit. So that's exciting. L-Glutamine, before you get too excited, is not too exciting. But it was studied in 2018. It was published in Blood, which is another one of the best journals out there. So very high profile studies on sickle cell disease. And the FDA approved it in the US, but Health Canada is not approving it. There were a lot of problems with the study. It was also a randomized control trial, which looked good. It showed some benefit. But there wasn't enough of a follow-up. And, this abstract was published saying in 2017, the FDA approved 2 medications. One was hydroxyurea for children, because it wasn't approved for children yet. We were using it off-label. And one was L-Glutamine for children and adults. The approval of hydroxyurea was long overdue for children, but the approval of L-Glutamine was quick. Why was it so quick for L-Glutamine? That's not been studied in sickle cell disease until now, when hydroxyurea has been studied for forever. Like I showed you the baby hug trial and everything else. Why did it take so long for hydroxyurea to be approved by the Food and Drug Administration? So anyway, any effective new treatment for sickle cell anemia is a welcome advance, but there are a few published studies of L-Glutamine as a specific treatment of sickle cell anemia. Accordingly, there are many unanswered questions about its efficacy, safety, and role in current therapy. So, and we agree, we reviewed the paper with some Canadian experts, and we don't think L-Glutamine yet is ready for full support from the healthcare community for sickle cell disease. Clinical benefit is modest, much more expensive than hydroxyurea. You can go on Amazon and look for L-Glutamine and buy it, but this trial is saying it has to be pharmaceutical grade L-Glutamine. That costs a ton of money. No long-term data about its use in sickle cell disease. It's well tolerated in the short term, but we don't know long-term. If used, it should be used with hydroxyurea, not just alone. And all sorts of other trials on L-Glutamine and other diseases are showing that it causes kidney problems, liver problems, multi-organ failure. These are things that we care about in sickle cell disease also. So we need to have more safety data before we can get too excited about it. Last but not least, SC is very different, SC disease, because the hemoglobin values are much higher. So in sickle cell disease, SS type, hemoglobin value is about 7 or 70, we say in Canada. In SC, it can be 12 or 120. And that has its own problems, because really high hemoglobin, when you have a sickle type of hemoglobin, can cause very viscous blood, almost like a molasses or syrupy type of blood. It's not good to have a really high hemoglobin when you have sickle cell disease. That's why, in fact, we don't transfuse a lot. Even when your hemoglobin is 70, we keep you at around 70, 80. That's good enough. Because if we give too much blood, it becomes very sludgy and can cause its own problems. So anyway, this is a study from Toronto, and there were other studies in other places looking at, well, why don't we remove blood from patients with SC? Because the high hemoglobin, it's not a good thing when you have sickle cell disease. Let's remove a little bit of blood. And they came up with this nice algorithm, and it works for them. We don't have any patients in my clinic yet that have agreed to this, but they took patients with adult SC disease with any chronic complications, one or more severe acute complications like vaso-occlusive crisis, acute chest crisis. If the hematocrit, or the concentration in the blood, is 35% or above, which is considered a risk factor for this sludgy, syrupy blood consistency, then consider measuring certain things with the blood, like viscosity, and phlebotomy to remove enough hemoglobin to bring it down to 9.5 to 11 range, or 95 to 110 range. If the hematocrit is low, which a lot of people do have low hematocrit, especially females, because of menstrual bleeding, their hematocrit can be lower, then maybe those patients don't need phlebotomy or bloodletting, because you can maybe cause anemia type problems there. So trying hydroxyurea in SC patients that have low hematocrit would be potentially an option. So I know there are some SC patients out there that feel that all the studies on SS don't apply to them. This is an option for you, but still hydroxyurea is an option, and it's used as part of this algorithm. So keep that in mind. I offer hydroxyurea to all my patients, regardless of type of sickle cell disease. So with that, we've talked about all the disease-modifying therapies. Blood transfusion is one of the main ones as well. It's been studied in children with stroke, etc., but we didn't spend a lot of time on it today. We can do a separate session on transfusion if needed. But I'm happy to take any of your questions.
Thank you, Dr. Saul. So we have some questions here in the Q&A. The first question is, someone was asking, how does haplotypes play a part in the efficacy of hydroxyurea?
So I assume haplotypes means the type of sickle cell disease, SC, SS, S beta thal. How does it play a part in the response to hydroxyurea? So the studies on hydroxyurea have looked at the most common types, S and S beta thal. And we haven't found a difference in response based on those two different haplotypes of sickle cell disease. So there's no reason to think that haplotypes would really be a huge factor in the response. So I hope that answers the question.
Thank you, Dr. Sol. The next question is, how young should one be for the CRISPR study?
For the CRISPR?
Yes.
So CRISPR, my understanding, and again, I'm not a gene editing expert, but the CRISPR studies I've referred patients to are taking patients in the teens and young adult years. So I think anywhere between 17 and 25. I don't believe they've tried it in really young children.
Thank you, Dr. Sol. Next question. Someone would like to know, so you mentioned that protracted cell reaches 70% in the blood work.
Mm-hmm.
And you check for effect of hydroxyurea on hemoglobin F. Please, what does protracted cell reaching 70% mean? What does that mean?
Yeah, so I think they're referring to this slide that I have up here. When we check hemoglobin, when we check the hemoglobin value and the hemoglobin F values, we're not looking at the amount of hemoglobin in each and every cell. What we're doing is we're ripping these cells apart in the test tube, and we're finding the average of all the hemoglobins in that test tube. So when the average in all of the cells is about 30%, we know from other studies that in each and every cell, there's probably about 70% cells that are protected from sickling. I know it's a difficult concept to wrap your mind around, but there's a difference between taking like 100 red blood cells, mashing them up and taking the hemoglobins inside of them and measuring them, versus taking each cell and looking at it with a test that we don't even have. So it's just a way to estimate. When your hemoglobin F reaches about 20 to 30%, we know that about 70% of your cells are protected.
Thank you, Dr. Sol. And this individual will also like to know how soon Voxelotor will be available in Canada and if it must be used with hydroxyurea.
Yeah, so if Voxelotor becomes available in Canada, it would be with hydroxyurea. It would likely be additive to hydroxyurea because all we have is the studies to go by, right? And the studies, I'll just bring up the Voxelotor study here. The study said, I think, a third of patients, so most patients actually stayed on hydroxyurea. So I can't advise my patients that it will be safe to come off of your hydroxyurea and just stay on Voxelotor, because the study we're basing is off of 274 patients, most stayed on hydroxyurea. So I would be, to give patients informed consent or information to make the decision, we have to be honest and say Voxelotor worked, but most were still on hydroxyurea. When it will be available in Canada is a question nobody ever can answer, because generally Health Canada is about 1 to 2 years delayed past FDA approval. So generally we find that once something's approved by the FDA in the US, Health Canada will start getting similar requests from pharmaceutical companies to approve it. So it takes about 1 to 2 years after the US approvals. But we have our own independent review process. As you saw with L-Glutamine, it was approved in the US, not approved in Canada. So it will be an expert panel essentially reviewing the evidence and really reviewing the benefit to patients that are Canadian patients. So that has to do with, will insurance companies cover it in Canada, etc. There's a lot that goes into it. And obviously, if it becomes an option in Canada, I'm sure Skago and Landry will be the first to advocate.
Thank you, Dr. Saul. So we have Hannah from the Kingdom of Saudi Arabia. Anna would like to know your experience in hydroxyurea therapy for patients with high starting hemoglobin F of 20 to 30%.
Yeah, so that's an excellent question. We know that in sickle cell disease, the hemoglobin F actually normally sits a little bit higher than the general population without sickle cell disease. So, you know, it can be about anywhere between 2 to 5% when it's supposed to be under 1%. So we give hydroxyurea with the hope that it will push that 5% up to 30%. But there are some patients with, you know, baseline hemoglobin F values of 20, 25%. You know, for those patients, you have to wonder if they have pure sickle cell disease or not, because there's another mutation called hereditary persistence of fetal hemoglobin, HPFH, which is also a mutation in the same gene that causes sickle cell disease. But that naturally protects you from sickle cell disease. It's like a very fortunate thing to have, actually. So it naturally protects you. So we would normally send more genetic testing to check that the patient has, you know, sickle cell disease on one gene and maybe the HPFH mutation on the other gene, which is a natural protector. Having said that, these patients can still grow up in their older age, can still have some problems like the bone problems and osteonecrosis, but they don't usually have severe sickle cell disease. They're naturally protected with their high hemoglobin F. So it would be a discussion. I think the benefit of hydroxyurea in someone who's already 22% would likely be minimal from the hemoglobin F perspective. As I told you, the other problems with sickle cell disease is the white cell adhesion, the platelet activation. So if you're finding your patient has symptoms, like maybe 2 to 3 pain crises per year, or maybe they're starting to see problems with retinal disease or bone disease on their x-rays, etc., then maybe talk to them about hydroxyurea to address more the white cell adhesion issues, the platelet activation. But you're right, following hemoglobin F in someone who already has high hemoglobin F is not going to be your indication whether it's working or not. It's going to be your patient's symptoms.
Thank you, Dr. Saul. So another question, somebody would like to know, what is the standard dose for hydroxyurea? I guess they're not in Canada, and I think the individual is asking from India. They're not sure what the standard dose should be for hydroxyurea.
Yeah, so the starting dose for hydroxyurea is 10 milligrams per kilogram. So let's say you have 70 kilogram patient, adult patient. Let's just say 50 kilogram adult patient, just to be simple. 10 milligrams per kilogram would be a 500 milligram dose, which is just a starting dose. But we find patients do very well with even 1,000 milligram starting dose. And I think I may have mentioned that there isn't really a maximum dose. There's a maximum tolerated dose, but there isn't a maximum dose. I have patients on 3,000 milligrams of hydroxyurea, which is like 30 milligrams per kilogram. So you start at about 500 or 1,000 milligrams. And it really depends on the size of the pill in your country. In Canada, it's 500 milligrams. I think in the US, it's 400 milligrams. And there are many, many manufacturers of hydroxyurea, so you have to figure out what the size of the tablet is. And you start them at about 10 milligrams per kilo. And every 1 to 2 weeks, you would raise the dose and check for how they tolerated that. I normally check complete blood count with a differential to check that the neutrophil count hasn't dropped or the white blood cell count hasn't dropped too much, reticulocyte count, and kidney function and ALT, which is liver function. I would do that every 2 weeks as I'm raising the dose. And of course, asking the patient, are you having headaches, fatigue, nausea? Some patients will have nail color changes. So if any of those side effects are not tolerated by the patient or they're too much to handle, that would be considered a maximum tolerated dose, and you would stay at that dose.
Thank you, Dr. Saul. Next question. So having highlighted the currently available therapies for sickle cell disease, would you advise they be used in combination or recommend that patients stick to one that works?
Yeah. So, I mean, it just depends on what we're talking about. Obviously, stem cell transplant is the cure. You don't need anything else when you have a stem cell transplant. Hydroxyurea, even in the trials, has been used along with the other medications. I would advocate that if two drugs work on sickle cell disease in two different mechanisms, then you use them together to get the maximum effect. We would have to have enough safety data that using things together is okay. And the example here is that the voxelotor trial had hydroxyurea along with it. I believe the crizanlizumab trial had something similar. So yes, I think if two medications work in different ways on the red cells and white cells and platelets, and we have enough safety data that's not going to hurt anybody, definitely. I mean, an example, and I don't like to give the example of cancer very commonly, but in cancer, when someone has leukemia, you give them 5 different medications to kill the leukemia. Because one medication works like this on the DNA, one medication works another way on, the mitochondria, one medication works a different way on disease sites that are hard to get. And so why are we limiting ourselves to a single drug that works in one way? If one medication is working for the patient, it's going to be an individualized decision with a discussion with the patient. But I think, there's a lot of diseases out there where we use multiple medications at the same time to treat them. So there's really, really great opportunity for these kinds of studies and optimizing patient care, especially if really stem cell transplant is not an option for someone, then, we would want to address their disease in any way possible.
Thank you so much for that answer. So next question, what is the risk to the sibling donor for stem cell transplant? So the sibling who is donating, what is the risk to them?
Yeah, so that's an excellent question. And, it's part of the process and the counseling that happens anytime you go for stem cell transplantation. So depending on how the stem cells are being collected from the sibling, it's either an IV or it's a needle through the bone, right? So obviously the side effects are, if it's a needle through the bone, that's going to be painful. And if there's sedation involved, there's that kind of risk. The other risk with the IV collection of stem cells is to get the stem cells at high numbers from the donor of the stem cells, you have to give them a medication in advance to wake their bone marrow up and say, make a lot of stem cells. So that medication is called GCSF, and it can give you bone pain because it's making your bone marrow make cells. It can give bone pain, it can give fever. So those are side effects. Again, we talk about the risk and the benefit. I think the other side effect is, there's a whole lot of psychological process of donating your stem cells to your sibling. What happens if they're not cured? How would you feel about it? So there has to be social work support to this whole decision process. It's not easy to think that you're giving life-saving treatment to someone and it doesn't work. So is that, you don't want people to feel that that they failed their sibling in some way, because it's not 100%. We saw that, you know, in about 10% of cases of stem cell transplant, it doesn't work. I think that's an issue that should be addressed from a multidisciplinary point of view. It's not just the medical side effects. There's also, you know, psychological side effects that we need to be addressing when having the discussion about a stem cell transplant, even when it's haploidentical, so mother to child or father to child. You know, there's excitement about potentially offering the cure, but you know, what if you're not a match? Does that mean you're you know, how would you feel about that? And what if you are a match but it doesn't work? So the medical side effects are very manageable. They're very well known. We give, you know, pain medications for them. They're usually limited to the donation period, and then once you've donated, you're fine. But then there's all sorts of other, you know, psychological things that need to be addressed at the same time. And transplant centers are very good with this. They know how to address it really well.
Thank you very much, Dr. Saul. So next question, where in Canada can one register for a donor match?
Yeah, so Canadian Blood Services has a one match program. So you call them, I think it's like, well, their website is blood.ca, blood.ca, and they have a stem cell transplant link. Or you call them on their 1-800 number, sorry, I don't remember it right now. And you tell them, I'm interested in your one match program. And if you tell them, actually, if you tell them that you're from an ethnic minority, they will love that. Because, you know, we have difficulty finding matches for sickle cell disease in Canada, or, you know, other populations that are ethnic minorities, if all the stem cell donors are Caucasian. So it's very there's a process. You can even donate blood, because even blood for ethnic minorities is difficult to match in sickle cell disease and thalassemia. So very highly desired. They have a whole separate program at Canadian Blood Services just for that. And Lonry is well aware of it and has helped to develop it as well over the time.
Thank you, Dr. Saul. So next question. Someone would like to know that if they cannot offer exchange transfusion to a child with S-beta tal 0 due to resources, but this child has frequent crisis, would a top-up transfusion with a higher target be detrimental, as this child is also on hydroxyurea?
So that's a good question. So the studies on transfusion in sickle cell disease were mostly done in stroke prevention. And they showed a huge benefit of transfusion when someone's at risk of stroke, or when someone has had a stroke and you need to prevent a second stroke. These studies did not specify if it's a regular transfusion or an exchange transfusion. They took anybody, any kind of transfusion. Of course, to the most efficient type of transfusion to prevent problems in sickle cell disease is exchange transfusion, because you can drop the hemoglobin S proportion much more efficiently in one day, basically. To drop the hemoglobin S fraction with a regular unit of blood or 2 units of blood, it takes multiple sessions that are more frequent. Plus there's that risk of iron overload. So what you're asking is, you know, can you prevent pain crisis by giving blood transfusion preventatively, you're saying? You can. You don't want to overshoot. I wouldn't go beyond the hemoglobin of 90 or 100 or 9 or 10 because of the risk of the hyperviscosity that I talked about. So yeah, resources are a problem. Even in Canada, we don't have exchange transfusion in every city. We have one in London, but it's only available for adults. We just recently started offering it to kids above age 15. So resource issues with exchange are everywhere. Very labor intensive. You need very specific nursing training to do it. What I do for patients, or at least what my pediatric colleagues do, for patients like Dr. Tolley and Dr. Kirby. I mean, you would have to speak to them specifically, but I think what they do is they offer hydroxyurea as the main therapy. And, if that's not working, you can do, adjunctive therapy or additive therapy with blood transfusion, as long as you don't overshoot over 10 hemoglobin. It can work. I reserve, personally, my approach is, because I have training in transfusion medicine, and I know, blood transfusions are not always without harm. My approach is only transfuse blood when someone is in severe pain, like during the episode, unless it's an exchange transfusion program and a chronic transfusion program. So I try to reserve the regular transfusions to chest crisis, or somebody who's really not improving with a chest crisis with regular care, or someone who's presenting with an acute stroke. You need to do quick transfusion. If exchange is not available, then regular transfusion. I don't know if I have a great answer to that question, because a lot of our experience is now with exchange, and a small number of our patients are on what we call simple transfusions. Even in the pediatric world, there's only a handful of patients in our hospital who are on simple monthly transfusions. We try to get them on hydroxyurea or exchange transfusion. Iron overload is terrible. So if you get 1 unit of blood every month, you can't get rid of the iron in that bag. It gets in your body. It gets in the liver. It gets in the endocrine system, in the pancreas. It can cause diabetes. It can cause thyroid problems. It can cause growth problems if the iron is really high. So the iron in the bag, it's problematic. And then everyone starts on iron chelation therapy, which means medicine to take out the iron out of your body, which has its own side effects. So I really love exchange transfusion and hydroxyurea much more than simple transfusion.
Thank you, Dr. So we only have about 6 more minutes, and we have about 4 more questions to go. So first question, somebody would like to know, what is the side effect of the CRISPR trial?
I have to plead ignorance here. I'm not an expert in CRISPR, but CRISPR does involve some drugs and chemotherapy drugs. So I would contact a CRISPR expert for that.
Thank you. So next question. So I'm going to go to the Marianne. So my daughter is approaching the 30% mark of her hemoglobin F. She has been on it since 2017 and is 10 years old. I'm assuming that she meant that her daughter has been on hydroxyurea since 2017 and she's 10 years old. How much higher could a dose go? She has experienced no side effects, and can she ever reach a plateau?
Yeah, so if your daughter is 10 years old, she's growing. Her weight will probably double by the time she's an adult. So that dose will eventually be smaller than what she needs. So what your doctor is probably doing is, as she grows and her weight increases, they have to catch up with the dose of hydroxyurea to keep the milligram per kilogram equal. So if you think she has no side effects, then is a good 30%. You might see over time as she grows that the hemoglobin F level will drop. And at that point, you can raise the hydroxyurea dose. Like I said, there's no ceiling to hydroxyurea. The more you take, the higher the hemoglobin F will be. It's very dose dependent. So unless you develop side effects like nausea, fingernail changes. Some people do have hair loss. So if that's something that matters to you, that might be a dose limiting issue. And the other thing is, hydroxyurea can result in bone marrow suppression. That's why we do blood work every about 2 to 3 months. So if you're not someone that does blood work regularly, you don't want to be raising your dose. If you're doing blood work regularly, raise the dose and monitor it. But yeah, my advice is there's no dose limit. As I said, I have patients on 3,000 milligrams of hydroxyurea, and they're doing well on it. Patients can, though, quickly develop side effects, so they have to be coming to clinic to touch base. Otherwise, side effects happen at home, and we don't feel comfortable with that.
Thank you, Dr. Saul. Next question quickly. How is L-Glutamine administered, and what is its mechanism of action? You mentioned that the study in the US regarding L-Glutamine was poorly followed up, but were there any studies conducted in Canada for it?
No studies in Canada for it. L-glutamine is, they don't really know the mechanism of action 100%, but the mutation in sickle cell disease, the gene mutation in sickle cell disease is L-glutamine, or sorry, not L-glutamine, glutamic acid to valine. So you have valine, you don't have glutamic acid. So theoretically, is it doing something there? I don't know. The mechanism of action is not very, very well known. L-glutamine is used in all sorts of other therapies. It's an amino acid. It's a type of protein. It's a food supplement, actually. But in high enough doses and what they call pharmaceutical grade L-glutamine, it seems to be benefiting. But my understanding is that the mechanism of action is not nailed down. Same with hydroxyurea. It took us years to figure out the mechanism of action of exactly how it works. So yeah, I think there's a lack of safety data, and so Health Canada is not jumping on the wagon just yet.
Thank you, Dr. Zoll. Another question. My son is 16 years old, 35 kilogram in weight, taking hydroxyurea since 8 years. He was started on 250 milligram, now taking 500 milligram for about 3 years. But he continued to have pain crises every 2 months for many years, with 3 blood transfusions per year. Isn't hydroxyurea acting?
I mean, 500 milligrams for a 16-year-old boy who's, I'm assuming, you say he's 35 kilos?
Yes.
35 kilos. Okay. He's not a very, very big guy, I guess. He must be on the thin side, I'm assuming. In that case, the doctors are probably worried about raising the dose too much. But if you go by 10 milligrams per kilogram, then 500 milligrams should be similar to that. If he's having no side effects, I would raise the dose and look at the hemoglobin F level, not just the milligram per kilogram weight. Yeah, but some 16-year-olds are like adult size. They're like 60 kilograms. So it really has to be weight based. I'm not saying nutrition is a problem. I'm just, we have to look at the weight, not just the age. So I think your doctors are doing the right thing by, being careful with raising the dose too fast. I would just follow the hemoglobin F level to make sure that you're achieving the target. Otherwise, if he's taking it for years and years and the hemoglobin F level is 5%, that to me, that's a failure of treatment. And I think you said he's still having crisis every 2 months with transfusions three times a year?
Yes.
So that's not sufficient. That's not sufficient treatment. I think the dose can probably be raised to 1,000 milligrams, or even 750 milligrams first, and checking for side effects.
Thank you, Dr. Soul. So as Dr. Soul said, you may need to discuss with your doctor to raise the dose for your son. Thank you for that question. I don't see any more questions here, and we're at the end of our time. I want to thank everyone that called in, and I want to thank Dr. Soul for giving the time this weekend to educate us. Please watch out for our next session coming up next month, and we wish you a very pleasant World Sickle Cell Awareness Month, September, and I wish you a lovely weekend. Thank you, everyone.
Thank you for having me.
Thank you.